Pointer, past president of the BC Pediatric Society, and I'm very happy to welcome you to this continuing education session this evening. Thank you very much for attending. We have a few housekeeping issues to take care of. Could everyone please type their full name, that is first and last name, in the chat box so that we can send out the certificates of attendance for your CME credits. Darlene will get your names out of the chat box. This session is being recorded. We will reimburse dinner receipts up to $15, and if you do have any, then you can email your receipt to Darlene at admin.bcpeds. When the session is completed, please remember to fill out the online evaluation form. There is a link to it in your registration confirmation email. I would like to thank Darlene and Brian for organizing this event, and also an extra special thanks to Darlene for the technical support this evening. And I, of course, would also like to thank Ramona Salvarinova, our speaker. So I just want to introduce Dr. Ramona Salvarinova. She is a clinical associate professor in the Department of Pediatrics at UBC and also the clinical director in the Division of Biochemical Diseases at BC Children's Hospital. Ramona completed her medical school in Europe and then continued her training at BCCH as a clinical trainee in the Division of Biochemical Diseases. Subsequently, she did pediatrics residency training at University of Saskatchewan and at UBC, which she completed in 2004. Ramona then pursued a 3-year subspecialty program in clinical biochemical genetics with the Royal College of Medical Geneticists training at BCCH. She's a fellow with the Royal College of Physicians and Surgeons of Canada and the Canadian College of Medical Geneticists. Ramona is a clinical director in the Division of Biochemical Diseases and co-lead of the Mitochondrial Multidisciplinary Clinic at BC Children's Hospital. She cares for pediatric patients diagnosed with inborn errors of metabolism and provides consultative services for pediatric patients within BC and Yukon. She has a special research interest in the development of innovative treatments for patients with rare diseases and is also an investigator and co-investigator in several clinical trials. So I'm very happy to introduce Dr. Salvarinova to talk to us first part of a 2-part series about mitochondrial diseases for the pediatrician.
Thank you so much. It's
one more thing. We're going to, I'm sorry, Ramona, I forgot. We're going to hold off on questions until the end. And then if you have a question, you can turn on your mic. And if you wish, you can turn on your camera and ask your question verbally. So we won't be monitoring the chat box for questions. Okay, go ahead, Dr. Salvarinova. Thank you.
Thank you. Thank you so much. It's a real pleasure to again be part of the presentations with the BC Pediatric Society. I really wanted to be part of this presentation, and I have to warn everybody that this will be a 2-part presentation. The first part you will see from the objectives, it's more on the clinical aspect of mitochondrial diseases, and the second part will be done by my colleague Dr. Brunel with focus on diagnosis and treatment. So I will first, I'm just trying to figure out, okay. I don't have any conflict of interest with regards to this presentation, but those are the general conflict of interest that I have. And going towards the presentation, as I mentioned, the objectives of this talk is really to get you more informed on an area of the inborn errors of the metabolism that is showing quite a significant expansion. This is an area focused on the mitochondrial diseases that has shown expansion not only in the basic science but also on the clinical part. So my focus on mitochondrial diseases has been long-standing, and I have been collaborating with the Mitochondrial Medicine Society in publishing with other members guidelines as well as other papers. And together with Dr. Brunel, we are co-leads of the newly established last year multidisciplinary mitochondrial clinic, which has a focus of getting together subspecialists who are involved in the care of mitochondrial patients, and all of that with the goal of really optimizing and improving their care. So with the ultimate goal that I see for our clinic to be part of the recognized mitochondrial centers within North America. But going back to the topic, there will be first more of a general part discussing about mitochondrial function, the genetics of mitochondrial diseases, and epidemiology. And the second part will be on general clinical manifestations. Obviously, there are many mitochondrial syndromes, and I will present several just to give you a flavor of the various syndromes. So we all know that the mitochondria are small organelles that are present within all of the cells, with the exception of the red cells, which are really what we call the energy power of the cell. We believe in the theory on endosymbiotic origin of the mitochondria has shown that this is likely an event that happened 2 billion years ago as a symbiosis between free living bacteria with the host cell that have been engulfed within the cytoplasm of the cell. With that way, the living cell was really obtaining a way of providing energy. And within that long of 2 billion years process, there has been changes, and obviously the bacteria has still remained to have some of the genetic material present. When we talk about the mitochondria, they are really vital organelles. And I think we are all aware on the part of the function that they have in our cells, in formation of energy. But there are also other multiple metabolic processes that the mitochondria are involved in our cells. And while the mitochondria in the past were considered as organelles that are just separate within the cytoplasm, nowadays we talk about mitochondrial network. So this is a more and more recognized organelle that is not even in a static state. On the contrary, there is a constant dynamic within the mitochondria as a combination of fusion and fission, and those processes are in a fine balance in order to provide adequate energy for the cell. So the fusion as a process allows the mitochondria within the cell to elongate, they become tubular and longer. And this is an opportunity for them to exchange material. The opposite process of fission allows creation of new mitochondria and also segregation of the damaged mitochondria. And these processes obviously have to be in a real balance so that the cell will function adequately. As part of that mitochondrial network that we mentioned, actually there is also a component of their ability to be mobile within the cell. And there are many molecular mechanisms that are now identified that allow the mitochondria to be transported, to be mobile within the cytoskeleton, which allows for improved quality control of the mitochondrial network. Another process that is also important is mitophagy, or the process of destruction of the mitochondria. And this process has to be in a real balance with the process of biogenesis of mitochondria. So if the balance is towards more of mitophagy or destruction of mitochondria, the cells will have deficiency in energy. On the other hand, having too many mitochondria may also be detrimental. And this will be reflecting into the overproduction of reactive oxygen species. So really this tells us that we need a fine balance within the cells. I think that the part that we are all very aware on the aspect of the mitochondrial function is their ability to generate energy. So the whole system of energy production is the oxidative phosphorylation system, is a system that is embedded within the mitochondria. So the mitochondria is actually an organelle that has a double membrane, with the inside membrane being quite convoluted. On the inner mitochondrial membrane are actually the complexes that are composing the OXPHOS system. So not going into details into their names, I don't think that is really relevant. There are 5 components of these complexes. The first 4 are part of the respiratory chain, where they're able to transport electrons, and as a result of this, there is also a transport of protons that are being pumped inside the intermembrane matrix. The resulting outcome of this developed energy gradient, electrochemical gradient, is the energy production at the level of the 5th component of the complex. And while initially it was felt that all of these components are really separate and they are independent, in an independent state, one of the other, nowadays there is more acceptance of what is called a solid state model, or super complexes, where multiple of those complexes are placed together. And this is felt to be likely reflecting the need for energy preservation and actually being more efficient. But as I mentioned, the energy production is probably the most of the well-known function within the mitochondria. I did use this slide not with any intention of going towards any pathway, but just to show you that this is really a complex organelle. And it is important because it does provide precursors for macromolecules like nucleotides and heme synthesis and cholesterol synthesis. It is also important within the aspect of the redox homeostasis, and also, as we mentioned, from the point of waste management within the cell. What I think is very important for us all to be aware is that the mitochondrial diseases occur as a result of changes in 2 genetic systems, and the mitochondria themselves have dual genetic control. So we have the nuclear genes and we have the mitochondrial genes, which are placed within the mitochondrial DNA within the mitochondria themselves. So this is obviously just a remnant of that much larger genome that was present, and over the years really has been reduced to only 37 genes. I'm mentioning this because mitochondrial diseases can be inherited in a variety of ways, and not only in the Mendelian pattern of autosomal dominant or recessive or X-linked, but importantly, it is the maternal type of inheritance. So I use this slide to emphasize few points that are important for us to understand how diseases happen and why there is such a spectrum of phenotype and severity within the patients. is a difference towards the mitochondrial DNA. I'm sorry. In difference to the nuclear DNA, the mitochondrial DNA is rather compact, and you saw that small circle of mitochondrial DNA. What is important is to know that this is a genome that is multi-copy. So within a cell, there can be or within a mitochondria, there will be multiple copies of mitochondrial DNA from 100 to 100,000 that is seen in the oocytes. And depending on those multi-copy genomes, whether those are identical, we will say that that genome is homoplasmic. If there are two types of DNA within the mitochondrial DNA genome, we will talk about a heteroplasmy. And this will be very important within the phenotype of the patients with mitochondrial DNA diseases. And again, the inheritance of this type of DNA is exclusively through the mother. I think this slide will show more graphically what is the meaning of homoplasmic and heteroplasmy. So these are cells that show different type of mitochondrial DNA. The blue ones are the wild type, or the normal, the healthy DNA, and the red ones are the mutant. So you can see that if we say homoplasmic DNA, it can be the mutant, being all of the mitochondria having the same mutant DNA, or all of them having the normal. And in between these two extremes, there is a spectrum of heteroplasmy, or a spectrum of what is the percentage of mutant and DNA versus the wild type. Important that different tissues will have a different threshold above which there will be not only biochemical, but also a clinical manifestation of a disease. And it will be different for various tissues, for various organs. Another component of the inheritance of the mitochondrial DNA is the so-called genetic bottleneck. This is a process that happens at two levels, at the level of the maturation of the oocyte, and also when there is fertilization of the mature oocyte. So the process of the genetic bottleneck allows to decrease the copy number of mitochondrial DNA. And this is really a random process. So within the mature oocyte, there will be really different proportion of mutated versus normal or healthy DNA. And definitely this will lead to different phenotype within the offspring of a mother. So still focused on the mitochondrial DNA, we know that the changes that occur in the mitochondrial DNA can be mostly of two types, point mutations, and the frequency of and the prevalence of those is quite high, as you can see. While the other component of changes are mitochondrial DNA rearrangements, and most commonly we see single deletions or parts that are deleted of the mitochondrial DNA. And later on we will talk about the three syndromes that are associated with these deletions. And depending on the severity, they can present very early on, which is the Pearson syndrome, or much later on in an adult age as a progressive ophthalmoplegia. The image here just shows you that the mitochondrial DNA does contribute to the complexes of the respiratory chain for all of them except for complex 2. A huge genetic information for the mitochondria actually comes from the nuclear DNA. And nowadays we know that more than 1,500 different nuclear genes encode nuclear proteins. So the changes in the nuclear DNA can also lead to defect within the mitochondrial DNA itself. And going now into the real world, I know that we usually think of all of the inversions of the metabolism as very rare. This is the estimated incidence overall within the population. And considering this number, I think actually these diseases are not so rare. Obviously, there is difference within the presentation in the childhood versus older age, and you can see that for children up until age of 16 are the numbers that are presented here. 5 to 15 cases occur per 100,000 individuals. One of the syndromes that are quite striking and really severe, the Lee syndrome, for example, occurs 2.5 cases per 100,000 births. And this is much higher, close to 10 times higher in certain areas of Quebec. When it comes to the adult prevalence, you can see that the 9.6 cases per 100,000 are actually due to mutations in the mitochondrial DNA, and less so due to mutations in the nuclear DNA. So I use this slide to really point out that although we are talking about mitochondrial diseases, actually in children, much higher percentage of the diseases is result of a nuclear DNA mutation. And you would expect those pattern of inheritance, autosomal recessive or dominant. Only a smaller percentage will be a result of mitochondrial DNA mutation. And the opposite is true for adult patients. If I can summarize and define mitochondrial with one statement, I think this statement really says it all. They can manifest at any age and in any tissue. And I hope that the message that we will get from this presentation is exactly this, to think of a patient who has really multiple system involvement, sometimes who do not really make a sense. And I think that is the moment when we need to think of mitochondrial disorders. And I think the following slide and the image from a paper from Gorman does point out that almost every system is really being affected as a potential in a mitochondrial patient. There are two peaks of occurrence, the first 3 years of life and also after teenage and up until adulthood. And I know that the newly diagnosed patients in the adult clinic, a big percentage are actually patients with mitochondrial disorders. So this part of the talk is really focused into giving you an overview of all of the systems and what are the most common features that present in patients with mitochondrial diseases. Obviously, considering that the central nervous system is a high energy dependent tissue, it is almost always being affected by mitochondrial diseases. And sometimes those can be manifestations that are clinical, for example, headache, or it is a clinical manifestation, but you can see changes on imaging. Some of them can be permanent and some of them can be transient. I think it's important for us all to remember that actually developmental delay is part of the phenotype that one can see in patients with mitochondrial diseases. I did put small flags, but I'm not sure that you will see them because of how the Zoom window is covering that area of the screen, but there are small red flags in some of the slides. Anyway, what I was trying to say with this slide is that the mitochondrial diseases can all present either with a global or isolated developmental delay, even features of autism or isolated learning disability or even attention deficit disorder are really sometimes a presenting feature of a mitochondrial disorder. Important to note that the mitochondrial disorders can be manifested with neural regression. And this neural regression is actually frequently seen with viral illnesses. One of the things that we ask the parents of patients is, how do your child respond to a viral illness? Is this an event that is really detrimental, or are they able to really, sail through a viral illness? Epilepsy definitely is a feature that is unfortunately quite frequent. It can be either a presenting feature or a late feature in the mitochondrial diseases. And it can present as either focal in quite a big percentage of the patient population. The seizures start with focal, but they can develop as generalized seizures. They can have myoclonus, infantile spasms, and unfortunately, recurrent status epilepticus has been described as well. One feature that is definitely a very striking and concerning is the occurrence of stroke-like episodes. These events are typical for MELAS, or the mitochondrial encephalopathy, lactic acidosis, and stroke-like episode, but they can also present in other features. What is important is that these episodes occur as a result of probably complex interaction. Of one hand, lack of energy. On the other hand, there is a lack of or deficiency of nitric oxide. And as a result, they are stroke-like episodes, which are really not following the vessel distribution, but they are reflecting this energy failure within certain part of the brain. Most frequently, they are located either in the occipital regions or the temporal or the frontal regions of the brain. And I think this slide does present this quite striking. Another feature that is quite frequent in patients are headaches. Headaches happen especially in patients who have one of the most common mutations seen in patients with mitochondrial diseases. What is important to know is that severe headache in a patient who has MELAS, or the tendency towards stroke-like episodes, it can be a prodrome and can be really pointing out to a syndrome or a stroke that is a stroke-like episode that will be developing in the patient. Movement disorder is another neurological presentation. Definitely the patients are at risk of not only altered tone, but movement disorder as a result of the injury that happens at the level of the basal ganglia, the cerebellum, the cortex, and they can be a variety of movement disorder and tone disorder. A very striking feature in the majority of the patients is myopathy. Frequently, if you have an infant with profound hypotonia, one should also consider mitochondrial condition, in particular if it is associated with other system and other symptoms. The myopathy can be of such a degree that the patients can have problems with swallowing, leading to aspiration pneumonia. As a result of the myopathy, there may be respiratory insufficiency. Myalgia and fatigue are quite frequent, and I do have and follow patients who have such a severe fatigue that sometimes they even sleep up to 19 hours within 24 hours. Usually we say that very high CK is not typical for the mitochondrial myopathies, but there can be some exceptions, of course. And other features in the mitochondrial diseases are neuropathy, which can occur either as a primary condition or a secondary in patients who have diabetes as a complication of their mitochondrial disorder, and sometimes as a result of the treatments. Cardiac involvement definitely presents in a quite significant percentage of the patients, and it is result of the high energy need that the heart muscle has. The features of involvement can be structural or functional, and again primary or secondary. And the next slide will actually maybe point you more to how to differentiate these cardiac manifestations. On one hand, there are reported conduction defects that occur in more than 10% of the patients. And really you can see a variety of arrhythmias and conduction defects. Much more frequent occurrence of cardiac involvement are actually cardiomyopathies, up to 40% of the patients. And when we talk about a mitochondrial disorder, the hypertrophic cardiomyopathy is more prevalent, but we still see dilated cardiomyopathy. We see histiocyte cardiomyopathy as well. And all of these systemic involvements are actually needed to be monitored for, and all of our patients undergo annual cardiac assessment, neurological assessments, and all of the other assessments based on the system involvement that we will be talking later on. So this slide does show heart, this is a transesophageal echo that shows quite dilated right and left atrium, really thickened walls of the ventricles. When it comes to pulmonary manifestations, usually the lungs are affected more of a secondary aspect due to the neuromuscular and the CNS involvement. These patients can have from difficulties with breathing, hypersomnolence, hypoventilation, pulmonary hypertension, and in a patient who has heart failure, definitely pulmonary edema. What is very important to know about the patients with mitochondrial disorders is that they are quite sensitive to anesthesia. And anesthesia may worsen the respiratory symptoms and provoke failure. So we always communicate with anesthesia, and we arrange for a consult for every patient, that in particular if they have a longer procedure. The gastrointestinal involvement is quite common, and important to know that the GI dysmotility is quite frequently present, and the patients complain of weight loss, of nausea. They feel full quite soon after their meal, and they really do not feel like they would be eating more. So maintaining the nutrition is always a challenge for this group of patients. One involvement in particular is the chronic intestinal pseudo-obstruction, which is defined as a period of more than 6 months of severe symptoms of intestinal obstruction, including pain, abdominal, nausea, and vomiting, with a radiographical finding of dilated bowels, but in absence of real mechanical obstruction. And again, having more increased episodes of pseudo-obstruction can be an indication of imminent stroke in patients with MELAS. I mentioned that this patient can have oropharyngeal weakness. A big percentage of patients can have liver dysfunction, and particularly liver failure is associated with the 3 genes that I mentioned here, POLG, DUGWOC, and MPV17. Those are in particular severe condition that lead to early liver failure and fatal outcome. On the other hand, exocrine pancreatic insufficiency can also be seen in some syndromes that we will mention later on in the talk. And obviously, obesity is definitely less of a feature in this patient population. The renal manifestation, I think there is a spectrum of phenotype that can be present, and this is all reflecting the high density of the mitochondria and the high level of energy that is required for the renal function. In the childhood onset of diseases, we more frequently see renal tubular dysfunction, somewhat more frequent glomerular in the adult population. Unfortunately, the chronic renal involvement may lead to renal failure, requiring transplant, and the most recent literature points that the outcome of these patients is similar with regards to longevity post-transplant to patients who do not have mitochondrial disorders. Endocrine manifestations, there is really a huge spectrum, and obviously we don't have enough time for all of this system involvement to go into details, and I just want to give you a really big overview of what one can expect with all of these diseases. The next slide does show, based on the different dysfunction, but also the genes that are associated with the various endocrine organs that are being involved. Definitely, of all of the endocrine manifestations, diabetes is probably the most common and very well described in patients with mitochondrial disorders. Endocrine manifestation can be both type 1 and type 2 diabetes in mitochondrial patients, and usually those features manifest later on in life. Just to point out the frequency of diabetes and the frequency of mitochondrial patients within the whole spectrum of diabetes, definitely this point mutation causes up to 2.9% of the cases of diabetes mellitus. When it comes to the phenotype of these patients, they usually present with non-insulin dependent diabetes, but frequently they progress to insulin dependent. And if you compare them to a patient who does not have mitochondrial disorder, it's a striking feature that these patients are not obese, they're actually failing to thrive. Another feature that is a quite common manifestation in patients with mitochondrial disorder is short stature. And you can see that in some, like Lee's syndrome, up to 90% of the patients will manifest short stature. This is seen both in patients who have nuclear mutation and patients who have mitochondrial DNA mutations. Treatment with growth hormone for patients who have proven to have deficiency does lead to improvement. And most of the reported cases have shown good outcome. I believe there's only one report where in 2 out of 4 patients there was concern with worsening of the primary mitochondrial condition. And not to forget the other manifestations, which would include involvement of the thyroid. Most of the cases, this is a hypothyroidism, but also hypoparathyroidism in these patients, as well as adrenal insufficiency, premature ovarian failure, and male infertility. When we talk about hematological findings, these are not so frequently present. Mild anemia is something that is seen frequently with the patients, less so neutropenia or thrombocytopenia. And I think we're all aware of the Pearson syndrome, where we have both pancreatic exocrine insufficiency and sideroblastic anemia. When it comes to the immune system, there is more and more data, mostly in vitro studies though, that show the mitochondria to be crucial for the normal function of the immune system. Although there are not many clinical studies that have shown this to be the case, there is still a study that has pointed out to a higher risk of infection and sepsis, and this is an area that is now especially expanding from the aspect of diagnosis and management. Eye manifestations are frequent, especially findings of ophthalmoplegia and ptosis, and there are a few syndromes where those are the crucial pathognomonic findings, but patients also can have cataract, nystagmus, and strabismus. When we talk about orthopedic complications, like in any patient who have multisystemic involvement, I think this is expected. The findings can be from scoliosis, spasticity and hip dislocation, and lip deformities. It is believed that from the aspect of psychiatric disorders, there is a higher prevalence in patients with mitochondrial disorder. Mostly these are manifested as anxiety, mood disorders, and major depression. And I think this is to be expected considering the complexity of this condition, and on the other hand, really limited treatment abilities that we have at this point. I will have to be honest. I think I wanted to point out that it is important how we address the mitochondrial diseases. There are multitude of mitochondrial diseases, and probably a good way to classify them is based on the clinical aspects. And most often we divide them in early childhood. I don't know if you can see that on the screen. Early childhood onset, like Pearson, like Alpers and Lee syndrome, and late childhood onset. So I think that does help into thinking of what phenotype the patient has. Another classification of the mitochondrial diseases would be the genetic one, where you can really divide the diseases based on the mutation, whether it is result of nuclear gene being affected or mitochondrial genes. And even further on, you can divide based on which complex or function within the mitochondria is being affected. But I think for the practical purposes, the clinical classification is most important. And in the next slides, I will try to summarize a few of the syndromes. There are really a huge number of syndromes that I don't think a presentation like this can capture them, but just to give you the flair of the variety of presentation. So you heard me mentioning Lee syndrome. This is a really devastating condition that starts early on. As you can see in this slide, and I tried for every of the syndromes to give you one slide that summarizes the most important point on the syndrome, followed by few slides that just add on. So you can see that this syndrome occurs very early. Patients present within the first 3 to 12 months of age. Lee syndrome can be caused both by nuclear genes, and I'm going to talk in this part about the nuclear etiology of Lee syndrome, but also mitochondrial diseases or mitochondrial DNA changes. What is striking for the Lee syndrome is that usually it is manifested with decompensation during viral illness. There is a psychomotor retardation or regression. The patients have hypotonia or spasticity, ataxia and movement disorder, hypertrophic cardiomyopathy, and elevated lactate. When it comes to Lee syndrome, as you can see, there is a huge spectrum. And again, this is a multi-systemic involvement. There are criteria that I will show in the next slide, which help into really classifying a patient within the Lee syndrome diagnosis. And if a patient does not really fulfill the criteria, then we talk about a Lee-like syndrome. What are the clinical manifestations? Although we mentioned at the beginning, the neurological manifestations are most severe with ataxia, with neuropathy, with ptosis and muscle weakness. These patients have extra neurological findings with cardiomyopathy, anemia, renal and liver involvement, and they can have hypertrichosis. And this is seen actually in many other syndromes. So the diagnostic criteria, and they exist for some of the syndromes and unfortunately not for all of them, include knowing the specific and fulfilling the diagnostic clinical manifestations, but very important is the brain MRI findings. And these patients have bilateral, symmetric, T2-weighted hyperintensity in the basal ganglia. Also part of the diagnostic criteria is elevated lactate and signs of disturbed oxidative phosphorylation. Of course, final confirmation is with the pathogenic variants in one of the genes associated with Lee's syndrome. I will only briefly talk about the diagnosis because there will be a separate talk, but I just wanted to point out that we base the diagnosis on biochemical tests, but also MRI studies, enzymatic activities, muscle biopsy, and of course molecular testing, which is now becoming the standard of diagnosis and care. And muscle biopsy, enzymatic activities are really, if our results on molecular testing are not as clear or not as differentiating. When it comes to treatment, it is mostly supportive, and only few of the nuclear encoded Lee syndrome have specific treatment. Alpers is a syndrome that occurs again in the early childhood. It is result of a specific mutation, and I mentioned the gene because I will mention it again into the end of the presentation. 3 features are important to remember. A child with seizures that are not treatable, with a psychomotor regression and liver failure. I still remember a child that presented after a few months of intractable seizures with signs of liver failure and ascites. And again, seizures are the most common presentation. They manifest usually with generalized tonic-clonic seizures. And important for all of these patients, not only for Alpers, is that valproic acid should be not used. I listed also features within Alpers syndrome that one can see. I'm so sorry. But I think the most striking are the presentation of the seizures and the liver involvement, which progresses, as I mentioned, to liver failure. Therefore, the life expectancy in these patients is limited. I mentioned Pearson syndrome. This is a condition that is result on deletion within the mitochondrial DNA, and it is manifested with bone marrow failure and needing transfusions, exocrine pancreatic insufficiency, and it may be fatal in infancy. And again, the anemia manifests very early on. There may be multisystemic involvement, As mentioned, these patients require transfusions and replacement of the pancreatic enzymes. Sanger system, I just wanted to mention the name, syndrome, mention the name, patients with congenital cataracts and hypertrophic cardiomyopathy. Milas is really a striking condition. I think we spoke about this at the beginning, result of mutation in mitochondrial genes, usually presents in the age below 20 years of age, less often in patients younger than 2 years of age. It's a multisystemic, progressive, manifested with stroke-like episodes, myopathy, encephalopathy, and lactic acidosis. And I believe that we mentioned all of these features. I'm not going to go over them again, but the striking moment in this condition is really the stroke-like episodes that are relentless, and they lead to slowly deterioration and dementia of the patients. Again, there is multisystemic involvement, in particularly the heart involvement, but there are endocrine and GI complications as well. For the diagnosis of Milas, there are certain criteria that need to be really completed within a patient, and there are 2 sets of criteria. Just to point out that there are also need for diagnosing Milas based on biochemical results, but also based on the molecular results, which are now the standard of diagnosis. As I mentioned, it is a condition with a progressive course, and unfortunately the median survival is 17 years from the onset of the neurological features. I did emphasize one treatment, and this is treatment with intravenous arginine. We administer it at the onset of the stroke episode. Within the first 3 hours, it is important to initiate arginine treatment to prevent the brain damage. Obviously, there is supportive and chronic treatment with oral arginine, but this is the most important treatment within an acute event. NARP, I will just mention that this is again a condition result of mitochondrial mutation, usually presents in the childhood, manifests with muscle weakness, and those are actually the first letters incorporated into the syndrome's name, ataxia and retinitis pigmentosa. This slide I wanted to show you to really show that the degree of heteroplasmy, or the percentage of the pathogenic mutation, affects the severity of a condition. Patients who have these 2 mutations as the most common mutations for NARP, especially you can see for this mutation, the T2G mutation, really up until 70% of heteroplasmy, they are not, sorry, for this mutation, they are asymptomatic. And the more of the mutation load is present, the more severe presentation. So depending on the heteroplasmy, you can see a patient can be asymptomatic or manifest with Leigh, which is a really severe condition. And again, there is really symptomatic treatment for this condition. There are multiple system involvement that require ongoing monitoring from the point of the heart, the hearing, neurological manifestations, and also psychological support. Leber hereditary optic neuropathy. This is a condition that is striking. It occurs as a rapid, painless visual failure. These are young, mostly males, within their 2nd or 3rd decade, which suddenly develop vision loss. It is interesting for this condition to know that there is a variable expression, and males are 4 to 5 times at a higher risk. So obviously there are other factors that affect the expressivity of a disorder. Also, individuals who smoke and drink alcohol have a much higher risk of manifesting this condition. And obviously, the most striking feature is the acute vision loss, but these patients can also have neurological manifestation, movement disorder, tremor. The multiple sclerosis-like illness has been mostly described in females who are carriers of the gene. Unfortunately, there is no preventative treatment. This is a striking vision loss. These patients are legally blind. There is treatment with the Debenon, which is really prohibitively expensive. And I did communicate with the manufacturer for a patient. The price was absolutely prohibitive, but the patients do find out ways of ordering it as a generic name. Here in Cyrus, I think if you recall, or if you go back towards this presentation, that this is part of phenotype as a result of large-scale deletion. The most severe phenotype is of Pearson with exocrine pancreatic insufficiency and features of anemia. The Kearns-Sayres usually occurs in the adolescent age, less than 20 years of age, again with retinitis pigmentosa, ophthalmoplegia, and for formal diagnosis, patient has to have either a cardiac conduction defect, ataxia, or elevated CSF protein. And this picture does show the salt and pepper retinopathy changes in a patient with Kearns-Sayre. Again, this is something more as a backup information to point out all of the system involvements. Unfortunately, the treatment is again symptomatic, but for some patients who do have folate deficiency, we provide them folate supplementation. And on the other, the most benign, if I can say, or the least affected presentation on that spectrum with mitochondrial deletion from Pearson to Kearns-Sayre is the chronic progressive ophthalmoplegia. These patients have ptosis, ophthalmoplegia, and proximal muscle weakness. And I will finish the talk with just 2 slides, just to point out how can we classify mitochondrial diseases by genes. I opted to show you for one gene, which is a really important gene. It's a nuclear gene. Now there are more than 300 known mutations in this gene. And the slide, I think, here shows everything. So depending on the type of the mutation, I'm so sorry. Depending on the type of the mutation and the effect that it has on the mitochondrial DNA, patients can present from the neonatal onset to really adult and elderly onset. And for some of this syndrome, we already spoke about. So I know that there was lots of information here, and I think if you can take back from this talk, the fact that these conditions are not as rare as we think. And important to think for mitochondrial disease in any patient that presents in your office with multisystemic involvement, really symptoms that can present and affect multiple organs, do think of mitochondrial disorder. And always do the family history and see, it will help you into understanding the potential if there is a family history, and be aware of the dual genetic control. And with this, I will thank you for your attention, and feel free to ask me if you have any questions. So I know that there were lots and tons of information within this talk, and I don't know if there's any question. I just wanted to give you an overview and give you a taste of the phenotype of all of these patients. As I mentioned, the second talk will focus on how to diagnose the mitochondrial patients and also the treatment modalities that are unfortunately still limited for our patients.
Ramona, this is Esther Lee with Complex Care.
Hi, Esther.
As you mentioned, yes, the part 2 will be on diagnosis and such. I mean, after hearing you talk, I just feel like, oh, anything can be mitochondrial. I can get it tomorrow, who knows, right?
Yes.
But just wondering on, you know, I think the whole genetic diagnosis, I mean, that's just exploding. Like, I mean, we see a lot of patients together where like everybody has done everything and we're just waiting for the genetic test to come back. Do you think, I mean, and I know a lot of it is still quite expensive to do, but is there more movement, do you think, from the government, like at the end of this diagnostic journey for a lot of these children, would like the hospitalization, all the various tests, really, when you add it up, probably it's cheaper doing the genetic test, or I don't know.
Yes, absolutely. I mean, I think that the exome sequencing and the gene panels are the future in diagnosing our patients. And when I mentioned that genetic classification, I think there will be time where every newborn will have an exome, and then you will have some genetic results where you will have to figure out, okay, where this patient is going to be, if there's any pathogenic mutation in the spectrum of what that mutation can present. I think the cost of the genetic testing is really coming substantially down. From what I know, an exome is now $1,700 compared to the tens of the thousand that it was. And absolutely, I mean, taking into account the investigations and the days spent in hospital, I think it's worth absolutely important. And I think there is a trend towards utilizing it more and more. On the other hand, I think it still needs to be in a way focused, because in general, the general yield of the exome is still around 30 to 40%. So a big percentage of the patients may not get an answer with exome, but definitely genetic testing is the future, and gene therapy will be the future for sure.
Hi, Ramona, it's Alex Faber. Thank you for a great talk. And also congratulations on setting up your new clinic. I'm very excited to hear that there's going to be a mitochondrial disorders clinic. My question is that for patients who already have a confirmed mitochondrial disease, or can we start sending them your way if we're thinking that they might have a mitochondrial disease for diagnosis and workup?
That's a very good thought. So I think that the initial goal was to at least get together the various subspecialties to discuss even the currently diagnosed patients. The number is still not big. I think we have maybe around 30 patients. We have not gotten to the point where we would be able, and that will be the goal, to have one place where all of the relevant specialties for that particular patient can see and give their input. I think that will be the future goal, but for now, at least we have a forum where we can discuss and exchange opinion and get an advice as to, you know, what is the best management or investigation for a patient, for example, who has renal involvement, or a patient who has seizure. So it is as a starting point, but I can see it evolve. I think if you have a patient with query mitochondrial disorder, just refer them to our clinic and they will be seen by any one of us, but we have this resource to communicate with the other subspecialties.
Thank you.
This is Darlene speaking. We've had a question come through on the chat as follows. When looking at the infant, child, or teen, what are early red flags to think about mitochondrial diseases?
In the infant
Child or teen?
or teenager, right?
Yes, yes,
Uh-huh.
correct.
So I don't want to repeat, that paradigm of any system or any age, but I would say for a small infant, any child that is manifesting hypotonia, severe hypotonia, a child that is really not recovering well with infections, a child who has already neurological features, and definitely when we have a patient, this is exactly what we do. We do make sure that there isn't any eye finding or cardiac finding, so that is part of the assessment for these patients. I think especially in a teenager, multisystemic involvement would be a trigger, or anything unusual like a sudden loss of vision. We had a patient a couple of years ago presenting exactly like that. So think of all of the systems that can be involved. I don't think that there is one specific feature, because there are so many syndromes and each of them presents in a different way. But the unifying thing is the multisystemic or more than one system involvement.
Thank you. We have another question from the chat. Is there a place for the TIDE, T-I-D-E, protocol as part of the workup, realizing we are no longer doing this quote unquote routinely?
Yes, yes. So you're right, actually, that, and I think there will be a presentation and a paper regarding the results of the TIDE protocol longitudinally, where it was shown that the yield and the pickup for patients with non-specific developmental delay is very, very low, and much lower than the study showed. I think the study had really specifically chosen patients that were quite severe, so it had a major effect into diagnosing them. I think that the TIDE investigations, to a degree, they will be helpful, like checking the lactate and amino acids, because if a patient has elevated lactate, there will be specific profile on amino acids. On the other hand, you can have a patient with mitochondrial disorder with normal lactate. So that all has to be taken into a context, and even the biochemical test, they may not be sufficient. That's why we usually go to genetic testing. So the TIDE protocol, I think, utilizing lactate, amino acids, organic acids would be helpful. And you will have another talk about really the diagnostic approach for the mitochondrial disorders. But that is a good question. And I do hope that there will be more of a formal presentation on the results of the TIDE protocol.
Thank you. At the moment, we have no further questions in the chat. If anybody does have one they'd like to add, now is a good moment. You're also welcome to unmute yourself and ask your question verbally if you prefer.
I think this was a really, really extensive talk, and I apologize for throwing so many syndromes and names during this talk, but probably I think you did get the gestalt of patient who manifest multisystemic involvement, patient who manifests regression. And that regression is a slow regression with some recovery, but never going back to the baseline where the patient started. There are some marks that should remind you to think of mitochondrial disorder.
We're having expressions of thanks for you, Dr. Ramona.
Thank you. I'm
It's
sorry
a great
that
talk. Thank you very much.
Thank you. Thank you.
Looking forward to the second half of the presentation. Great overview on mitochondrial diseases for a pediatric resident with little knowledge on mitochondrial diseases.
Oh, thank you. And I think that is my my other goal, to really include the pediatric residents and provide them with some more teaching. So maybe this can be a start into that regard as well.
At the moment, it's looking like it's quiet on the chat, so we may have come to a conclusion of that particular portion of our time this evening.
Thank you. It has been a real pleasure, and thank you so much for the attention and for really useful questions. So I do hope that we will have another opportunity to communicate and share patient experiences.
I invite Avon to join us verbally if she's ready now. At the
Yes, thank you very much. Thank you very much, Ramona. That was, as you said, was a very good gestalt. So I have, and I think everybody else has kind of a bit better feeling for mitochondrial diseases. And we're looking forward to the next presentation, which Darlene will be sending out the information within the next little while. Everyone, please remember to, excuse me, complete your evaluation, which is on SurveyMonkey, and Darlene sent out a link with the information with regard to tonight's presentation, and as well, she put it in the chat. Thanks a lot again, Ramona. Good night, everybody.
Thank you so much, and good night.
Thank you. This is Darlene. I'll be the last one off the call after everybody has a chance to end.
Thank you, Darlene. Thank you for your help.
Oh, my pleasure. I'm glad it went so well. Thank you.
Thank you.
I'll touch base with you offline about receiving a copy of your PowerPoint so that we can put that on our presentations portfolio in our website.
For sure, for sure. Thank you.
Thank you.
Thank you. Bye-bye.
Bye-bye. Have a good evening.
Bye.
Bye. Bye,
Bye.
everybody.